All right. Well, welcome everybody. This is our panel discussion. We're going to review the first two cases that we presented here, and we'll take any questions that you have in the chat. And so I'll start it off by asking Dan and Jen. Just we have a question that has come in about OCT angiography and sort of how we use that in some of our complex patients. And so maybe I'll start with Dan and maybe give us your insights on where OCT angiography fits into your diagnostic algorithm.
So I think OCT angiography, it's a very powerful imaging modality, but I don't really use it too much for glaucoma. I really reserve it for kind of my retina cases. In glaucoma, I think the major question is, are we losing those blood vessels before, during, or after we lose those RNFL axons, before we have ganglion cell atrophy? So until we answer that question, I don't know if it's that useful for our kind of day-to-day clinical glaucoma cases, unfortunately.
Anything to add,
Yeah,
Jen?
I would agree. Yeah, I would agree with you here. We are collecting data on our patients, so we often will perform angio just to get a baseline. But at this point, we don't really have a set protocol as to how we're utilizing this information. But because we have the technology, we think it's important to start collecting so that in advent of some new information comes along, we have it available to us.
I think that's a great point. I think same thing with GCC. We don't even know the power of the tools that we have. So it's nice to get the data. It's nice to sort of collect a lot of the information. And then down the road, maybe we'll start to see some patterns that make sense to us. It's hard to know right off the bat. But I think as Dan pointed out, really it's all about, understanding the fact that we are limited. We cannot actually measure rates of perfusion yet, which is really what we want OCT angiography to hopefully one day be able to do for us. I think for now, we still have some great tools. We have, our different types of analysis using the visual fields, using the OCT. And so, I want to go back to that first case. And Dan, we talked about the rapid progressor. And I'm just curious, walk me through your treatment algorithm for a patient like this in terms of, so you have somebody who's newly diagnosed, they're moving kind of quick on you. And this was a question in the chat. What are you aiming for in terms of your target reduction, your target IOP reduction, and how quickly are you advancing treatment?
So it really depends on, where you first kind of find this patient. If the patient already has advanced glaucoma, I do want to be pretty aggressive. Of course, depends on what their Tmax is, where they're starting off in terms of their IOP. But usually I'll pretty aggressive and try to get the IOP down to maybe the low teens. So, if we go according to ages, we want maybe less than 13 on our advanced glaucoma patients just to make sure they're not progressing any further, because once they are advanced, any progression can really reduce their visual function significantly day to day.
I got a question for you, Jen. Are you telling them a target number? Classic debate in glaucoma. Do you tell them what you're going for? Because I feel like, I don't know, for me at least, I'll tell you my answer is probably no, because the moment at least one of these New York patients hears that they're outside the range, it's like, I'm going somewhere else. This doc's not cutting it. I'm just curious what your thoughts are.
I would love for patients to not realize that we're even monitoring eye pressure. We're just assessing the nerve. We're looking at things. I can show a picture. I can share a picture. But I try, as you pointed out, to steer the conversation away from that quote unquote target IOP as best as I can. And I think we have come to realize that that always isn't a great indicator of progression, right? So we know the definition of glaucoma is progression. So it's really just a matter of keeping track of that and finding the rate of it. And that target pressure may not actually be our target come to be. So I totally agree with you.
Yeah, and I think that target number can change over time. I think sometimes we don't even understand the full extent of the volatility. So it's really hard to set a number when truthfully we're working with very little bits of information. And I think, as you said, it's really all about putting the whole picture together. It's using all the tools and the software analysis that we have to really see what is this patient's chance of going functionally blind in their lifetime. I have plenty of patients who are doing fine at a pressure of 22, and I have patients going, blind at a pressure of 15. So it's really, really hard to really assess a target. But I think all of us do have numbers in our head. We all will start off with our prostaglandin analogs, move on to our combo agents. I'm curious, are you both using Rho kinase inhibitors? Have you found that to sort of impact your practice in terms of trying to get to some of those low teens pressures for some of these advanced patients? What are your thoughts about SLT earlier in the algorithm? So maybe Jen, you could talk about Rho kinase inhibitors, and Dan talk a little about SLT.
Mm-hmm.
Sure, yeah. So we found a lot of success in the rho kinase inhibitors, and I think they're a great option, especially when you have a stubborn eye that you're just not meeting pressure. Of course, they come with a lot of side effects that we have to point out to patients, and sometimes that can, significantly deter. But a lot of our patients, especially patients who maybe are awaiting surgery, and we want to get that pressure lowered until their surgery date, it tends to work out quite well for us as well. It's another place I'm using it quite often.
Yeah, and your thoughts on SLT? We're hearing so much. We got the light trial data. I think it's very exciting. I think many of us, at least I've come around on it. It's something I did not do early in my practice, but I'm doing much more of. Are you recommending SLT to more of your patients?
Yeah, I think the new data coming out, I am recommending it more and more. Maybe I'm just like a bad salesman, but patients still tend to go for drops unless they're the younger patients. The younger patients, I think, because they feel that SLT is less disruptive to their lifestyle. They're still working, they don't want side effects, they're going to go on vacation, they go on weekend trips, so SLT is easier for them. So I find that younger patients will tend to opt for SLT. The older patients will start with an eye drop, so probably a prostaglandin I'll start them on. Usually, if they need more than just a prostaglandin, then I'll again bring up the conversation of SLT, and at that point, they're usually more amenable to it because they don't want to have to use 3 drops a day if they're using a prostaglandin plus a combo drop BID. So that's kind of my workflow in terms of treatment.
I think those are great points. I think we're going to see a big shift in terms of, what patients want. I think a lot of our older patients do enjoy going to see their pharmacist. They're often their best friend. And a lot of our younger patients are really looking for, other ways to, treat their glaucoma without having it such an impact on their life. So we had a few poll questions, and I want to sort of take a few seconds here to spend some time on them. So we talked a little bit about tests and issues with false positives and having high false positive rates. And maybe, Dan, maybe you could just touch a little bit upon, your thoughts in terms of what you do with a test that has a high false positive. Is it a test that you're totally ignoring? Is it something that you're looking at, you're repeating, in the near future? What are you doing when you get a lot of high false positives, and why is it an issue?
Yeah, so I think it depends how high the false positives are. If you're getting 15%, 20%, I'm not just going to throw away that test. I think you still have some useful information, but you do have to look at the actual decibel values, I think, of at least a few of the points on the overall field. Because if you're getting sensitivity values of 40s, then that's an unreliable test. But if it's only a few decibels above what you would expect, maybe compared to what the previous visual field was, and I think it's still pretty useful information. You don't just throw it away. Now, of course, if you have a kind of white field where you have 40s, 50 decibel values, that unfortunately you do have to throw away.
I mean, I give those patients a round of applause. I tell them they did a great job. That test looks so much better. In the last minute that we have, Jen, hit us. How often after an intervention are you retesting visual fields in OCT? I think that's the big money question from this, both of these cases. How often should we be testing our patients?
Yes, I usually try and do it within about 3 months after their last intervention. And, one of my reasons for that is we know, especially with glaucoma surgery, there's a lot of fluctuation in vision in the first few weeks after surgery. So trying to get things kind of stabilized, give, the eye some time, get that vision a little bit more stable before we retest and reset our baseline.
Yeah, I think there's a lot of great evidence out there, a lot of different papers, suggesting how often to do testing. And it's hard. It's hard to have sort of a set algorithm. Certain patients are better at testing than others. Certain patients are more willing to test than others. You want to get that right amount of information, but not necessarily have too much information where you have too much noise. And so, I think these two cases nicely illustrated, kind of how we all go about taking care of our patients. And, really it's a pleasure working with you both. And, I think, hopefully, down the road, we can, do another one of these webinars, and I can continue to learn from both of you. Any last minute, quick teaching points or take home points from either of you?
I think the biggest thing is just, talking to your patients and not being too hesitant on offering some treatment options that you wouldn't have necessarily thought of earlier, like SLT or MIGS.
And I think just looking at all the data in context of the patient, because our landmark studies, they look at hundreds of patients in research setting, but when you're in the trenches, you really got to look at the context of the patient themselves.
And I think you both brought that up a few times tonight. Just listen to the patient. All this testing is great and it's helpful, but really there is no better diagnostic tool, I think, than taking a good patient history. So with that, thank you, everybody. It's been a lot of fun, and look forward to the rest of the webinar.
Thank
Thank
you.
you.